give a talk on the current evidence on vertebroplasty. Vertebroplasty was first described back in '84 and kyphoplasty in 1998 by Mark Riley. The only difference between the two treatments is that in kyphoplasty you try to reduce the fracture before injecting cement. The aim of these treatments are basically pain relief and for the kyphoplasty to re-establish the vertebral anatomy. The primary indications when first described back in '84 was vertebral metastasis, but during the 90s it was suddenly osteoporotic vertebral fractures that was the main indication, but at myeloma it's a very good treatment too. The exclusion criteria are, as you can see on the slide, infections, retropulsions of bony fragments, and dementia is only not a real contraindication, but I use it as a contraindication because when I'm treating the patient, I'm doing it in local anesthesia, so you need the patients to be able to cooperate, but you could just do the procedure in general anesthetics. As shown, diagnosis, ordinary plain X-rays, MRI is the examination that I choose, and the steer sequence is the easiest to use because you can see the edema on the scan. The technique is local anesthesia. You instrument transpediculate and leave the needle up here in the middle third of the vertebra and inject the bone glue. And for kyphoplasty, you use the same entrance, but before injecting the glue, you just dilate the bone temp to try to create the height of the vertebra. Nothing is free in this world. Vertebroplasty, there's a lot of complications, and the main is PMA leakage, infection, vascular reactions. And osteoporosis is, as we have just heard, general disease. And why is this so interesting? And that's because a huge amount of elderly citizens get compression fractures. The incidence is increasing. 8% of the patients are estimated that they actually need hospital care, and it has got a huge impact on their daily activities. And as Christina just shortly mentioned, it also creates one thoracic fracture compromises the vital capacity. Looking at the evidence for this treatment, if you go in on Medline or PubMed and just write vertebroplasty and kyphoplasty, you get approximately 700 papers. And among this huge body of papers, there's only 4 randomized studies. And the maximum follow-up on these studies is only 60 months on 70 patients from a Spanish study. Kyphoplasty, there's only 1 study, the free trial, and the maximum follow-up is 1 year, but I know they've just published a 2-year follow-up or presenting that later today. Looking at the randomized trials, a paper from last year from David Kalmus, they randomized 130 patients, 60 for vertebroplasty and 60 for sham. The patients were allowed to cross over after 4 weeks, and they could not show any difference between vertebroplasty and sham after 1 month. But an interesting thing is that 64% of the patients in the sham in the PVP group experienced a good pain reduction, whereas in the sham group only 48% experienced pain reduction, and the crossover, 43% of the patients in the sham group wanted to crossover. Another study is Rachel Bookbinder's from Australia.